Thank you, Dr. GBK and team, for inviting me to give a thought on this particular topic, CANVAS trial. Exactly, this is called CANVAS program because CANVAS trial was a combination of two trials, CANVAS, the mother, you can say CANVAS, and then sister CANVAS R, and if you combine it, it will be called CANVAS program. Now, topic is, has it changed our practicing approach? I thought that I will present something different because you have heard, IMPAREG outcome trial 2000 times, CANVAS maybe 1500 times. So you are bored with those slides. So I will just skip those slides very quickly in 2 slides. But then I will put focus on what we actually bother about this trial, where we should go ahead after that amputation and fracture fiasco, where we should go ahead. So, as expected, like all the CB outcome trial, this was a 3-point MES trial and came with a conclusion that canagliflozin were able to reduce the composite of 3-point MES, as you can see, by 14%, and this 3-point MES was combination of cardiovascular death, non-fatal MI and non-fatal stroke. What was interesting to note in the CANVAS program was the benefit was strikingly similar to what we saw in the IMPAREG outcome trial, which was also 14% like in this CANVAS trial. We also saw that benefit was not extended only to the 3-point MES, which was the primary objective, but it also extended to the heart failure hospitalization, although this was exploratory, or you can say secondary outcome, like the IMPAREG outcome trial. Remember, none of the trial actually primarily looked for heart failure, so this was an exploratory outcome also in the IMPAREG, and so is in the CANVAS trial. And we also saw that there was a benefit of heart failure hospitalization by 33% in the CANA arm compared to placebo. And if you recall, in empagliflozin IMPAREG outcome trial, there was 35% reduction in the hospitalization due to heart failure. When you look into the renal endpoint, because these trials also looked for the renal endpoint, but again remember, this renal endpoint were again exploratory outcome, similarly like IMPAREG outcome trial, and there was a benefit in the different renal endpoint, the best which was the composite of the 40% reduction in EGFR, end-stage renal disease or renal death, because that's the hardcore evidence. Albuminuria progression and regression, we know there are many drugs which reduces that, but there are hardly any drug which actually reduces the composite of the renal mortality data, and there was 40% reduction in the composite of renal outcome, exactly similar to the IMPAREG outcome trial. It was 39% in the IMPAREG outcome trial. The only difference was one of the parameter of 40% reduction in EGFR was there in the CANVAS. So by and large, if you look this study, and if you go little further into the renal data when you compare CANVAS with IMPAREG, the CANVAS, if I have to give merit in terms of renal endpoint, I will give 1 marks more to the CANVAS in this regard, especially in the renal outcome data. You can ask me why, because answer is pretty simple, that CANVAS R was predominantly a renal outcome trial, where the primary objective was to look for albuminuria. That was not, the objective in the IMPAREG outcomes trial. And if you take CANVAS R alone into the picture, where primary objective was to see the, progression in albumin excretion, there was 36% reduction in the CANVAS R alone. As you can see, even the p-value of interaction is statistically significant, thereby suggesting that CANVAS R was different from the CANVAS mother trial by showing that despite the albuminuria was the primary objective of this particular study, there was 36% reduction in the proteinuria. Having said that, these are preliminary evidence which suggests a SGLT2 inhibitor may be renal friendly drug, and we have to wait for a dedicated renal endpoint trial. We know that Credence trial with canagliflozin is currently under progress, and we expect the result on hardcore renal endpoint in 2019. So in nutshell, if you see the CANVAS entire story and the result, this is what I have summarized. There was a reduction in the 3-point MES, but it was not due to reduction in any of the one of the component of that 3-point mesh. It was due to the summation of the reduction of the effect in the CB death, non-fatal MI and non-fatal stroke, which is in contrast to the IMPAREG outcome trial, where the primary benefit was seen in the cardiovascular death. And I will compare what happened in two trials. As I have talked about, there was 33% hospitalization for the heart failure reduction, and so was the progression of albuminuria and renal composite endpoints. So naturally, people tends to compare two trials together, although it is not, ethical or correct way to compare two trials which has been conducted in a completely two different set of patients with different kind of setting of the context as far as the secondary outcomes are concerned. Nevertheless, we tend to compare those trials, and if you compare IMPAREG and CANVAS head to head, there were three certain difference which was seen between IMPAREG and CANVAS, and this difference was because the IMPAREG only showed the reduction in the cardiovascular death, which was by 38%, highly statistically significant, and that also derived the beneficial effect on the reduction in all-cause mortality by 32%. So this was two additional gain in the IMPAREG outcome trial, which was not seen in the CANVAS trial. Nevertheless, there was also some signal of increase in the stroke by 24% in the IMPAREG outcome trial, although that was not statistically significant, but that was not seen in the CANA trial. So in one hand, you have got two additional benefit, CB death and all-cause mortality in the IMPA. There was signal of a stroke also in the IMPA. There is no such harmful signal as far as these outcomes are concerned in the CANVAS trial. However, so in a clinician, for a clinician to understand how does this two trials looks for us, the IMPAREG trial was conducted in a patients where everyone has pre-existing established cardiovascular disease, like in 99% of patients had heart disease, whereas in CANVAS only 65% of patients had pre-existing cardiovascular disease, 35% patients were a primary prevention cohort. So if you compare IMPAREG and CANVAS, IMPAREG people were more sicker in the sense they had established cardiovascular disease, whereas CANVAS had less sicker patient because they had a patients without cardiovascular disease but having only high CV risk factors. So if you are generalizing this data into clinical practice, this suggests that IMPAREG is clearly showing benefit in a patients with established cardiovascular disease, which may not be every one of your patients in clinical practice, whereas CANVAS program applies to the mixture of patients with primary and secondary cohort. Now, if you are real statistical analyzer, we always tends to debate actually whether this benefit is similar or dissimilar. To me, it looks like these benefit with IMPAREG and CANVAS is more similar than the dissimilar. Whatever dissimilarity we got in the IMPAREG and CANVAS trial is perhaps due to difference in the kind of cohort which was recruited in IMPAREG, 99% with CBD versus only 65% of CBD in the CANVAS trial. So we thought that let's go a little bit harder into understanding whether difference lies between IMPAREG and CANVAS trial. And if you make a correlation analysis, it's not a tough slide to understand. What this suggests that if you see the correlation graph of IMPAREG and on both sides it's a 95% confidence interval. This paper is currently under publication, but I thought to say here, there is no difference in terms of the benefit which was seen in IMPAREG and CANVAS. Both are showing a linear correlation in terms of benefit, and if you see the p-value, both are highly statistically significant. But if you make a fight between the two agents in terms of benefit and you do a linear regression analysis between IMPAREG and CANVAS, you come to a conclusion there's hardly any difference. I don't know whether you can see my cursor or not. It's not going there because, so you can see that the difference actually in the linear regression, there is no difference between IMPAREG and CANVAS. You might be surprised how it is coming, and that's a very interesting point in statistics. What you need to understand that what you are actually plotting into the x-axis and to the y-axis, The difference lies between the treatment arm and the placebo arm. That gives you the absolute risk reduction in these CB outcome trial. If you plot the different CB endpoints here, that includes CB death, all-cause mortality, MI, stroke, everything, then and do a linear regression, this suggests that there is no difference as far as benefit between CANVAS and IMPAREG is concerned. Now then, after the CANVAS trial, there is also growing real-world evidence which is supporting that SGLT2 benefit is not, a unique property of IMPA. As we can see also in CBD real data, this is a real-world data from 6 countries. You can see more than 3 lakhs patients where 50% DEPA was used, 45% CANA was used, only 5% patients were IMPA, only 13% had established cardiovascular disease. So it's a primary prevention cohort trial. And the unique of this particular trial was this is the only trial in the planet as of now which looked for heart failure hospitalization as a primary outcome. And if you see the result here, there was a heroic, outcome in this trial. And if you see the heart failure hospitalization comes to 39%. And if you recall, in IMPAREG it was 35%, in CANVAS it was 33%, now this is showing 39%, pretty going on similar in line in terms of hospitalization due to heart failure, being the primary outcome at this particular trial. Also, the secondary objective was to see the all-cause death, and you can see there was 51% reduction, and if you compare with IMPAREG, there was 32% reduction, although these data looks exaggerated, but this happens in any observational studies which overestimates the result. Well, then the next paper was next real-world data is called EGEL study, and again this is a similar kind of trial like CBD real. The difference between CBD real and EGEL is here everyone has got a heart disease like in IMPAREG outcome trial. Here 58% patients were on CANA, 60% on DEPA and 26% IMPA, 25,000 odd patients from US Department of Defense military. And if you see the primary objective of this study, and I have just wrote it here, don't go into the data only. Basically these data suggest that these benefit which we saw in the CB outcome trial is basically supplemented by the real world data. No real world data has shown no benefit with the SGLT2 inhibitor, whether it's a heart failure, all cause, whatever kind of data you want to see. Now this is a paper which is specific to canagliflozin. Now come to the one molecule alone and compare with the CANVAS. You can see this is just recently published in BMJ. 2.5 lakhs odd patients, 2.5 year follow-up, 23% only CBD, and they compare CANA with 3 active comparator, DPP4, GLP-1 and sulfonylurea. Remember in CANVAS trial, we compared against placebo. In this real world data, the CANA was compared to DPP4, GLP-1 and sulfonylurea, and it was astonishing to believe that benefit happens across the spectrum. Whether you compare CANA to DPP4, 30% reduction in heart failure hospitalization, compared to GLP-1, 39, compared to sulfonylurea, 49, only suggesting that the benefit which we saw in the CANVAS randomized control trial is being supplemented through the real world data. Although you can comment, because these are the real world study and people did commented that the benefit which we saw is over exaggerated, too good to be true, and this keeps on these kind of commentary coming, and that's the limitation of any real world data. It's not a huge rocket science here. Now we also have got one data which is perhaps the first mechanistic data where the benefit with SGLT2 inhibitor was looked for, and this was a trial conducted with canagliflozin in older adult patients. This was basically a phase 2-3 trial data pulled together, and they looked for 2 important markers. You can see here troponin I on your right hand side, and you can see here this is what marker, this is pro-BNP. So anti-pro-BNP and troponin I, CANA versus other agent, and you can see clearly that this is first biochemical evidence which suggests that SGLT2 inhibitor, I'm not saying this will be with the cana only, it will be with the all SGLT2, this is my belief is, but for the first time, this was the first mechanistic data which suggested that there is a clear-cut reduction in the heart failure marker in the form of NT-proBNP and ischemia marker in the form of troponin I, as you can see in this mechanistic trial. Now, this is a reason why, if you see the ADA 2018 ADA ESD algorithm, they have come with a clear statement that if you have used metformin, then before you going to the second drug, you look whether patient has got atherosclerotic cardiovascular disease, yes or no. If you find the patient has got a atherosclerotic cardiovascular disease, use the agent, and what agent that I will tell you. If patient doesn't have existing atherosclerotic cardiovascular disease and you have used metformin, then you can use any drug, sulfonylurea, insulin, whatever you wish to use, pioglitazone. But if the patient has got existing established heart disease, then you must use the drug which has been shown to reduce cardiovascular event. And ADA further reiterated, and it looks to be little frustrated comment, that see here in this particular supplementary, and the ADA is again further going and saying, if a patient with atherosclerotic cardiovascular disease is not yet on an agent with the evidence of cardiovascular risk reduction, consider it. ADA is begging, it looks like. Do use this drug because of the benefit which we saw in IMPA-REG, CANVAS and the LEADER trial. And what was those agent? The ADA recommended that if your patient has got established heart disease, you can use 3 drugs, IMPA and LEADER. They have got evidence A, and the evidence A is because FDA has given additional leveling to be used to reduce cardiovascular death with empagliflozin and liraglutide, and that's why evidence level is A. And with the canagliflozin, evidence level is C. Wait for the CANA's FDA's IMDAC meeting, which is going to happen 2 months from now. We will see whether the CANA also come through like empagliflozin and liraglutide. But then this is not the point to compare IMPA or CANA. The point remains is that ADA basically suggests that use any of these 3 drugs if your patient has got established cardiovascular disease. Naturally, no discussion will complete without this particular part, which we saw unexpectedly in the CANVAS trial, and this was amputation, which was, you can see here, was twice higher in the CANA arm compared to placebo, and so was the lotoma fracture. You can see here 1.2 times higher in the CANA arm. Let's take one by one. As a clinician, what should we look for? The amputation data. There was no dearth of data which did not suggest amputation with CANA. So be very clear. The CANA was surely showing amputation, although if you see the different marker that was lying at the 6th number in terms of the thing causing amputation, but it was clearly there. So you can't deny it. The only good part of this is, the bad part is we got it. There was amputation which was unexpected. There was no signal whatsoever in phase 2b3 with the any SGLT2 inhibitor. But the only good point as a clinician, because the drug has shown the merit in reducing cardiovascular risk reduction through 3-point mesh, that this amputation in the CANA, and if you compare versus placebo, is a very low level of prevalence. If you see, there was 6 amputation in CANA versus 3 amputation in placebo in patients, 1,000 patients treated for 1 year. So the absolute difference becomes 3:1,000. This prevalence rate, as far as any adverse event is concerned, is too low to be considered. Fortunately also, the Indians are less prone to develop peripheral vascular disease compared to Western population. That is another solace for the CANA manufacturing people. But then people also need to talk whether IMPA has got any such kind of signal. I don't want to go into that, but there was some signal, specifically in 2 arms, female arms, and patients on diuretics had some increased incidence of amputation also in the IMPA-REG outcome trial. And that is the reason why, if you see the EMA labeling, they said that, sorry, you have to put a label to all. In IMPA-REG outcome trial, amputation was not measured as robustly as it was measured in the CANA trial. And you calculated the data retrospectively without taking into account that it was not the motto of the trial, it was not the specific point to look for. But FDA naturally is going to give you a labeling, and FDA put a level of black box warning on cana in terms of amputation. After this in the CANVAS trial, then few more paper published on amputation. I would like to show you this particular interesting data. This is data from the pharmacovigilance. On your left hand side, this is data from FDA adverse event reporting system, and they also ascribed cana to be causing amputation, whereas it was not with the IMPA and the DEPA. This very recent data by WHO Global VG base, which is a global database by WHO. Now this database recently showed that all the 3 SGLT2 had increase in amputation. Only DEPA was little outlier. The DEPA had only 2 amputation, but the below knee amputation was seen both with the cana and the IMPA. So these pharmacovigilance data is confusing to us. In one hand, this is only showing with the cana in the FDA, whereas in WHO, it is showing with all the SGLT2 inhibitor. If you go the real world data, this is further confusing. On your left hand side, this is the data comparing all the SGLT2 inhibitor with non-SGLT2 agent, and you can see there is no difference in the amputation with all the 3 SGLT2 inhibitor compared to sulfonylurea, metformin, pioglitazone, insulin. So this is the first real world data suggesting no evidence of increase in amputation. On your right hand side, you see there is increase in amputation even in the real world data, higher with the cana, also to some extent with the IMPA, but this trial was not powered to compare between 2 agents. Finally, so what about amputation? This review article just published 2 days back in Nature Reviews of Endocrinology by Andre Sin, which analyzed entire amputation data. I have already shown you, so don't worry about that. And basically this data is completely confusing. In one hand, one data is suggesting increase, other data is suggesting no increase in amputation. So then as a clinician, what next to look for? Simple answer is we have to wait for DECLARE TIMI trial. This is the only trial which has been given such a liberty to choose, peripheral arterial disease patients and look for amputation. And FDA has recommended them to do even a biomechanistic data to look for why there was increase in amputation seen in CANVAS trial. I am not going to reading into details, suffice to suggest that if the DECLARE TIMI trial suggests that there is increase in amputation with the DEPA, this is a class effect. Simple. No, hair pulling. If it suggests that there is no increase in amputation in the DEPA, then cana alone has to get blamed. Simple. No hair pulling, simple answer. Wait for the DECLARE TIMI, that will answer you. The fracture issue, it was seen in the CANVAS trial, but fracture data is completely, having a heterogeneity in the sense that there was signals of increase in fracture in the CANVAS, but if you see the CANVAS R, there was no increase in fracture. In fact, there was decrease in fracture. So this is inconsistent data in terms of fracture, even in the IMPA outcome trial. This perhaps suggests some other mechanism. If also see the graph, the fracture has started happening pretty early. It can't be due to any bone mineral changes. Similar kind of fracture was also noticed in IMPA outcome trial. So please be careful. This suggests that these things perhaps might be happening because of, perhaps because of fall. So ladies and gentlemen, to conclude, regarding the CANVAS trial or IMPA naturally comes into the discussion. I feel that both CANVAS and IMPA together suggest that the SGLT2 class are cardiorenal protective. The cardiac data is clearly there, renal data we have to wait for, but there is all possibility that even this renal protective data would be translated in the CREDENCE trial, but wait for that particular data. The difference in the IMPA and CANVAS on CB death is not a rocket science. There's no reason why one should have and another shouldn't have. Is perhaps because of difference in the cohort of patient in IMPA, which has got all heart disease patient, and that of course will benefited more with a drug which has got a CB protection compared to the CANVAS which had 35% patients with primary prevention cohort. However, a direct comparison is not formally possible given the difference between the two trials. So what to do till then? Simply, this is my belief. More clarity is required whether this is a specific to cana or this is a class effect. If you ask me, I personally feel that it is a class effect. Wait for the DECLARE TIMI. We will meet again here. But then till then, avoid all SGLT2 inhibitor in patients with diagnosed or history of peripheral arterial disease or prior or current amputation. Thank you very much for your patience.
Thank you.